Okay. So I'd like to introduce Dr. Anna Krasno, who's going to talk to us about autism and diversity in therapy, building understanding and practical tools for clinicians. And before we introduce her, we'd like to do a land acknowledgement. So we acknowledge that our lands are located on the ancestral homeland of the Chumash peoples, and that as the original stewards of this land, the Chumash understood the interconnectedness of all things and maintained harmony with nature for millennia. Indigenous communities have lived in and moved through this place over hundreds of generations, and Indigenous peoples come from many nations, live and work in this region today. We pay respect to their ancestors, their elders, and their communities, and commit to supporting their healing, their dream, and their journey. So I'll pass it off to you, Anna.
Thank you, Amanda. Hello, everyone. I'm really excited today to talk to you about my passion, which is autism, and also neurodiversity. Thank you so much for being here. I have a lot I want to share. You're always welcome to reach out to me afterwards. At the end, I have my email, contact information. So my name is Anna. I'm the clinical director of the Kegel Autism Center at UCSB, where I train the doctoral students in assessment practices and clinical practices and run our clinical services. And I also have a private practice called Autism Assessment Santa Barbara, where I conduct neurodiverse affirming evaluations for all ages and identities. Okay. So just a little bit more about me. This is my family. The kids have grown up. So on the right, you can see they're a lot older than on the left. And I have a mini long-haired dachshund who's 10 years old named Odie, who's my soulmate on the bottom right. So I've been in the field of autism for about 18 years. I'm not neurodiverse identifying. I do have neurodiverse family members. I've worked with hundreds of autistic and neurodivergent individuals over the course of my career thus far. I've done a lot of different academic training, but honestly, my actual training has been listening to autistic and neurodivergent voices. So my goal today is not to speak about neurodivergent people, but to speak with respect to their insights, strengths, and challenges. And then my passion, as I mentioned, is accurate assessment for folks age 14 to 75 years old. I've never worked with a 75-year-old, but I have seen a 70-year-old for assessment, first-time autism diagnosis. Throughout the presentation, there'll be different pieces of artwork that are by autistic and neurodivergent folks, and there's a credit with their name if you want to seek out more of their art. So for today, we will be talking about neurodivergence and the neurodiversity paradigm, then going into the autism diagnostic criteria, specifically understanding how we can reframe the spectrum using difference-based language. And then lastly, discussing neurodiverse affirming and strength-based care considerations in the therapeutic setting and getting to questions as well. So to start us off, I want to go over some terms. These words are changing all the time in the field of autism. On the left, we have outdated terminology, and on the right is what we understand to be current terminology, but it changes very often. So on the left are the terms that I was trained with in graduate school. I graduated in 2014, and I was taught to say person with autism, so person first language. We were at the end of the DSM-4, we had Asperger's and PDD-NOS. Now we think more about identity first language. And so saying autistic person, autistic child, this comes from listening to autistic people express the way that they want to be referred to. And you can always ask. The terms Asperger's and pervasive developmental delay not otherwise specified are no longer diagnostic terms in the DSM-5. We have autism spectrum disorder, or ASD, but I like to just say autism. I like to de-emphasize the disorder piece of it, and I'll go into more about how the DSM uses such deficit-based language when it comes to autism and how that leads to all sorts of bias in culture and with clinicians. So I just like to use the word autism. Neurotypical or normal, we prefer to say non-autistic or allistic. These are more objective terms. Autistic is a term put forth by the autistic community to describe non-autistic people. Treatment is also a word I no longer use. We talk about support services for autistic people. We are not treating the autism. We are providing supports for autistic people in a wider range of areas where they might need support. And we're talking about affirming differences and not training autistic people to be less autistic or present as less autistic for others' comfort. And I'll go into a little bit more about what that means and what that looks like. Warning sign and red flags, these are still very widely used in the medical field when it comes to a lot of different things. And in autism, I really like to talk about how couldn't we just use more objective terms? So characteristics or behaviors. When we're using warning sign or red flag language, this makes someone think that it's an emergency, it's a crisis. We have to find it early. We have to change it. We have to fix it early. And a lot of the history of the field of autism research has focused on that. And we're really shifting now or talking more about neurodiversity affirming care. We still use language focused on deficits and disorder. This is how the DSM writes it out. We prefer to model talking about autism using difference-based language. And a little bit later, we'll look at a couple pieces of the autism diagnostic criteria in both the way it's written in the DSM now, and then also how we can reframe that using difference-based language. High functioning and low functioning, again, these are still pretty widely used terms. We prefer talking about support needs or level of support needs. Minimal and high, it's still a little too binary. So this term could evolve. But when we're talking about a high functioning person, what we've heard from a lot of autistic people is that this is a misnomer. It leads to them thinking that they can't seek out support because they've always been told that they're high functioning, they can figure it out. Why can't you just figure it out? And so this leads them to feel a barrier to seeking out support when they really need it. And similarly, low functioning, using that term, one might assume that someone can't do something that they can actually do. And then we have neurodiversity, neurodivergent, neurodiverse. These are new terms that really I've only been using maybe in the last 5 years. And then masking and camouflaging of autistic traits, which I'll also speak more about, is this experience where autistic people unconsciously or consciously work to hide their differences. And this can lead to a lot of physical and mental exhaustion and mental health concerns. So just a graphic to show you sort of that difference between identity first language and person first language. When we're thinking of person first language, it's as though this experience is outside the person and it can be put down and picked up at will. And this really isn't part of the autistic experience. It can be a piece of someone's identity. And so that's why there's been this shift to the identity first language. I want to highlight a couple autistic voices. There are just really wonderful resources out there now. Websites, blogs, books by autistic people highlighting their own unique experiences. I just have two here. The first is Paige Lyle, who got a diagnosis as a young adult. And a quote from her is, "We may act as though we're the same as you. We smile, but we dissociate when we touch a texture we don't like, or when the lights are too bright, or when we can hear every watt of electricity surging through the kitchen at night. We pretend we don't actually notice. We pretend it doesn't bother us. We try to have meltdowns and shutdowns in private to avoid being punished and ridiculed for disruptive behavior. We go through life struggling to stay afloat while it looks like everyone around us is doing just fine." I include this quote because she's emphasizing the hidden experience of autism and that autism can be a hidden disability. And she's masking all day, trying to look as though she's fine. We also have Catherine May, who's a late diagnosed autistic adult. And she puts forth that there's no single defining version of autism, but instead an overlapping of multiplicity of minds. The term spectrum is a poor way of capturing the sheer diversity of our experiences. It's too linear and too fixed. When I imagine us, I think of a constellation instead, or perhaps a galaxy. Millions of different stars shining, each expressing their fire in a different way. I include this because we often think of the spectrum as a straight line, and most people gesture like this when I'm talking to them about the spectrum as being a straight line. I have a graphic later I want to share with you about a different way of viewing that. But I love how she kind of blows that up here and uses stars and a galaxy and constellation to describe autistic people. So we're going to do something, we're going to use the chat. So thank you so much for your participation. I'd love for you to take a moment to think about how many interactions you have with humans daily. So in person or texting or email. So if you could put in the chat, I'll pull it up. How many interactions do you think you have daily with other human beings? Thousands, 20 to 30, thousands, hundreds, 25, 50, 20. Yeah, so lots. Let's see. Thank you so much, everyone. Okay, yeah, hundreds. So I'm seeing a range, 20 to thousands, and that's super fair. Probably depends on the day, how many people you interact with. But I would argue that if you actually counted them up, we'd be in the thousand range, because you might not even be counting certain things that are going on. Thank you so much. And so, yeah, I mean, every day, right? You're maybe grabbing coffee, you're having a group meeting, you're chatting with a friend, you're meeting with others to do other things, or maybe it's just an online conversation. You're having an argument with your partner, then you're hanging out with friends, you're meeting new people. Let's see, where am I? You're chatting more, you pick up your kids. So it kind of goes on and on and on and on. And I want to kind of bring your attention to what it is that you are doing in these social interactions. So take a moment to think about everything that goes into a brief social interaction. I guess I'm thinking an in-person interaction. Even 1 minute. What is going on in that minute in terms of the language that you're using or listening to, your sensory experience, and then also the social elements of that. So as it comes up for you, if you could volunteer your ideas in the chat, that would be great. Connecting, noticing cues, responding, sharing, noticing. Thank you, Deborah. Eye contact, facial expressions. Thank you, Denise. Body language, verbal language, thinking, feeling, looking. Yeah, reading nonverbals, decoding language, thinking of how the other perceives you. Awesome. Yeah, no, these are great. So yeah, there's a lot going on. I'm seeing listening, thinking, feeling, looking. So there's some things people are naming that are observable and then things that are more hidden. And I'm wondering who taught you how to do these things? How do you know what to do? How do you know what you're doing in that? Did you have a class on it? Did you have a teacher for it? How did you learn it? Did it just happen? Observational learning, watching, experience. Yeah. Some come naturally, some taught. Awesome. Perfect. Thank you, Victoria. Spent a lot of time learning from books and classes, practice. Amazing. So there's a lot going on in social interactions, and I would argue that most of it is not explicitly taught. So folks can seek out books and lessons and classes and groups, but there's no class in school that's going to teach you how to do these things. And each interaction is very, very different. So in terms of language, there's so much going on. This is not an exhaustive list. Spoken word, tone of voice, the pacing and pausing, sarcasm, idioms, eye contact, gestures. You can see the list here. There's a lot going on. There's the sensory pieces, smells, other talking, lights, residual impact on your body and your mind of what's happened in the day thus far. There's the clothes on your body. And there's the social piece, the turn taking, the listening. Am I being polite? How are they perceiving me? What social role do they have, like in relation to me? Am I their superior? Are they my superior? The cultural norms that are going into the expectations of the social norms, and also the perspective taking. So what are they thinking about what I'm saying? What are they thinking about me generally? And so as I'm talking to you, I'm monitoring my facial expressions, I'm using gestures, I'm trying to look as though I'm trying to make eye contact virtually with all of you. I'm thinking about how, if you're enjoying this presentation, if it feels helpful, if you're bored, if you're sleeping. I'm thinking about the way everything has happened in the day thus far. And I'm also able to filter out the feeling of clothes on my body and the lights and the sounds and the sirens going by. And so why does this matter? All of these pieces that I would argue, even in a 1-minute conversation, we could probably come up with 100 different things that are happening, can be quickly, naturally, and seamlessly integrated by non-neurodiverse brains without expending much effort. Autistic brains can experience each of those pieces as discrete skills that are brought together quite effortfully. And so it makes more sense to their brain to perhaps not give eye contact because then they can listen better, or not integrate gesture with eye contact and vocalization because putting all of that together takes so much effort that I can't remember what you've told me. Or if I'm making eye contact with you and then I have to think about what facial expression you're showing and what does that mean? And are you actually being kind or are you using sarcasm? Like it can go on and on and on. And if we're thinking about maybe potentially thousands of social interactions a day, you can see how much effort this would go into doing each of those pieces for an autistic brain. I want to highlight also that someone's sensory experience, which can be hidden, can significantly impact someone's ability to interact. And I want you to consider how these aspects may impact responding quickly to verbally based questions, responding quickly to social cues, and also understanding implicit rules in social settings. So neurodivergence and the neurodiversity paradigm. We know that 1 in 31 people are autistic. This number comes from a study the CDC did of children, but we so often don't acknowledge in the field of autism that children become adults. It has been widely ignored. And I'm so happy that all of you are here today. A lot of you may be working with adults who can learn more about what autism is to support adults in your practice. In any space of about 30 people, there is likely an autistic person. We also know that 1 in 5 people, or 20% of the population, are neurodivergent. Neurodiversity is much more of an umbrella term. So a naturally occurring variation in neurological wiring that can impact life functioning. This is just one graphic. There's a bunch out there. It can include many different things, and there's also ongoing conversation about even what more it could include. I focus on autism in my presentation because that's where my work is. But dyslexia is actually the most commonly occurring form of neurodivergence. And then we can see how there are overlap because there are people with autism and dyslexia, autism and ADHD, et cetera, et cetera. So this presentation will not be able to go over all the different forms of neurodivergence. We would be here forever, but it is really important not to forget that these are distinct things that have specific experiences under this umbrella term. The term was coined by an autistic Australian sociologist, Judy Singer, in the 1990s, and it has really offered a shift from the medical model of our understanding of disability to a social model understanding. It focuses on strengths, but does not dismiss challenges or disability, fosters community identity, and really offers a complete reframe of the conceptualization of disability. And so I have a graphic to show you next. and really puts forth that disability results from a mismatch between the person and the environment. And for me, this was a really big aha shift moment that was so different from my graduate training, where we were taught medical model based, that a diagnosis lies within an individual, and that individual has the responsibility to change who they are to better fit in with society. And this model puts that on its head. The infinity symbol on the right, the rainbow infinity symbol, is the symbol embraced by the neurodiversity movement. In terms of puzzle pieces, those are no longer used in autism, as autistic people have really shared that those graphics make it seem like if we just find the last puzzle piece, we can all be cured or fixed. And so no more puzzle pieces. And so I often use this neurodiverse infinity symbol. So this table is from an amazing book called Is This Autism? A Guide for Clinicians and Everyone Else. It's written by psychologists who have autistic children. I highly recommend it. They've been on several podcasts. It's just really great. So they explain this medical model versus neurodiversity paradigm. So the core assumption of the medical model is that there is a normal way of being and that anything different is inherently bad, a flaw that requires correction. The neurodiversity model says there is no normal. Brains come in many varieties. No two brains are alike, and there's no better or worse. There's not a judgment on it. If we follow the conceptualization of autism in the medical model, is that it is a disease or a disorder. It's undesirable and categorically bad. When we're looking at the neurodiversity paradigm, autism is a part of human biodiversity and on an individual level is an inherent part of a person's identity. Then when we're thinking about disability, like I mentioned in the medical model, disability is thought to be a defect within a person. And in the neurodiversity paradigm, disability results from a poor fit, excuse me, between a person and their environment, and the lack of environmental support or flexibility is disabling. One example I see all the time of this is autistic college students at UC Santa Barbara. They are bright, they got in. The structure of the university, the quarter system, the lack of support, the general ed classes, the forcing you to live off campus because there's not enough housing and take a bus in. I mean, I could go on and on. UCSB is not a good fit always for autistic people. And it doesn't mean that autistic people need to change who they are to fit in better with UCSB culture. UCSB should be changing to be less disabling for autistic people so that they can graduate college. And then when we're thinking about the goal of support in the medical model, the goal is to make the autistic person look less autistic. Historically, autism treatment has been to train autistic children mostly to show non-autistic social skills like eye contact, gesture use. In grad school, I worked on eye contact as a goal with children. I would never do that now because now we've learned listening to autistic people that eye contact can be very uncomfortable, if not painful, and people can show other ways of listening. And in the neurodiversity paradigm, the shift in the goal of support is to help the autistic person be their authentic self, right? That's the goal. In therapy, we're helping people be their authentic selves. Why are we not doing that for autistic people? Or why have we not been doing that? How do we affirm difference and also equip people with a skill set that they're seeking? So moving into reframing the criteria using difference-based language. Deficit-based language is all over the DSM, right? It's rooted in the medical model. It's from a system that needs to quantify dysfunction and justify treatment, justify insurance coverage, systems that, systemically rely on proving impairment or disorder to allocate resources. and particularly when it comes to autism, uses completely arbitrary social rules to decide what is abnormal, quote unquote. The DSM lacks strength-based, person-centered, or context-sensitive language and reflects the Western biomedical model that emphasizes what is wrong with the individual. The impact that this has is manyfold, but some of the things that come out of this is that it's stigmatizing, individualizing, so all the wrong is in the person. It's overlooking systemic, social, and environmental factors. It's pathologizing, so in a sense, neurodivergence being viewed as a disorder or an illness. And it really leads to diagnostician bias and misunderstanding. Because when you're reading the diagnostic criteria for autism, it describes a certain type of person. And many people who I diagnose with autism you would never apply this type of description to. So for example, current DSMs, there's 3 social communication criteria. This is B, deficits in nonverbal communicative behaviors used for social interaction, ranging, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and using gestures, to a total lack of facial expressions and nonverbal communication. So when you're reading this, you may think of a particular presentation of somebody where you can see everything is observable to you. This is telling me that I can look at someone and tell if they're autistic because I'm going to see poorly integrated verbal and nonverbal skills. I'm going to see abnormalities in eye contact, and I'm going to see a total lack of facial expressions. This is just not how autism presents every single time. And in our practice at UCSB and in my private practice, we're starting from the very beginning in our adult services support program and our assessment program, where we're using difference-based language the entire way, so that by the time we get to the assessment feedback, we've already shown the person that we are thinking of it in an objective, difference-based way. In every assessment feedback, we describe the diagnostic criteria, but we shift it. Oops, so a possible reframe. There can be differences in eye contact, gesture use, types of facial expressions, and the integration of these behaviors with language. There can be effortful integration of non-speaking communication behaviors. There can be differences in how one interprets social cues and situations. It can also be the case that these differences are hidden. The individual has tried to teach themselves how to do the skills and does them with great effort, resulting in physical and emotional distress. So you can see the shift here to less definitive type language, that there can be these challenges or differences, and also alluding to what might be going on underneath the surface, things that are not directly observable, the effort that could go into reading social situations, and that these differences can be hidden, where someone has tried to teach themselves, and that can lead to success, and sometimes it can lead to misunderstandings. But when we're describing the criteria in feedback, this is how we're talking about it. If we look at a criteria that is under the restricted and repetitive behaviors and interests piece of autism, and I'm going to be talking more about the specifics of autism in a second. We see highly restricted, fixated interests that are abnormal in intensity or focus. For example, strong attachment to or preoccupation with unusual objects, excessively circumscribed or perseverative interests. So again, why do we need to use the word abnormal when we're talking about someone's passions? Why do we have to use the word unusual? Like, people like different things. I've worked with kids who really like to carry around a spatula. I've worked with kids who probably know every word of K-pop Demon Hunters and all, like, everything about it and all the history about it. Both of those kids can have autism. So a possible reframe, the individual can engage in their areas of preferred interest for long periods of time. They like to learn everything they can about the topic. These interests may change over time, but there exists a pattern of a significant depth and passion to each interest. These interests serve a regulating function and bring joy. We're making a shift from this being a pathologizing behavior that we need to mitigate or change into actually like a really beautiful area of strength that leads to such amazing and great knowledge. I've learned so much working with autistic people about so many topics I never thought I would. I've learned a lot about tarantulas and their behaviors day to night, like night to day. I've learned a lot about bone collecting and how to like wash animal bones and put them together into jewelry. I mean, things that are just incredible. Um, and when we're reading them as such pathologizing behaviors, it just isn't what is being presented in front of you. Okay. So I'm going to talk about the autism diagnostic criteria. I'm not going to break it down into the DSM type categories. You can always read your DSM for that. I really am wanting you to think about it differently. I want to be modeling for you how to talk about what has been considered for so long such a stigmatizing and pathologizing diagnosis into something that is just a difference in brain wiring, a difference in what someone's brain is drawn to, a difference of salience of attention that can bring joy and can be disabling as well. So some core features of autism include differences in social communication and interaction. So autistic people may interpret social cues differently. There can be differences in that back and forth conversation. So it could be that someone likes to talk a lot or at length or in detail about their interests and what they'd like to share. There may be less asking of the other of what they would like to share. Or maybe it's someone who asks a lot of questions and a lot of in-depth questions of the other person. It can be someone who prefers not to engage in small talk or much back and forth interaction at all. They may prefer to use more direct or literal language. It can sometimes be more challenging for autistic folks to understand non-literal language or sarcasm. There can be differences in eye contact, facial expressions, or small talk. Autistic people can make eye contact. Autistic people also sometimes don't make eye contact. It's been thought of as such a defining feature, and it really isn't. They can find group settings or unstructured interactions challenging and benefit from explicit and clear language and expectations. Something simple we think about at UCSB is how we write our emails to the people who we work with. We always have clear, direct language. We have it be very clear, are we asking for a response or not? We make it very clear what the next steps are. And there can be challenges understanding friendships and relationships. There can be, differences in understanding who makes a good friend. How do I pick a partner? How do I avoid being taken advantage of? How do I not take someone at their face value when they might actually be intending harm? At the same time, lots of autistic people have partners and spouses and children. We also see repetitive behaviors and interests. So autistic people may enjoy structured routines or rituals. This might be on the more micro level. So their morning routine, evening routine, maybe on the more macro level of their like kind of annual routines or rituals. They may engage in repetitive motor or vocal behaviors for self-regulation. So you may have heard the term self-stimulatory behavior. This can be both repetitive motor or vocal behaviors. A very classic example is hand flapping. Maybe if you're working with an adult who used to hand flap but was ridiculed or stigmatized for doing that in public, they may have taught themselves or shifted to do repetitive motor behaviors that are more discreet or only flap their hands in private. They may have deep focused interests in specific topics and have a preference for predictability and sameness. So maybe that's they like the routine. They may like to wear similar clothing, eat similar foods. Changes can be distressing and hard to tolerate. And then sort of conversely, there can be challenges with sometimes flexible thinking as well. So we can see that autistic folks like to think about things in maybe more all or nothing or black and white ways, and it can be harder for them to find the gray. Sensory processing differences was included in the diagnostic criteria in the DSM-5. It wasn't previously in there. And I feel like this is a piece that is often overlooked because it's usually not observable. It can be very, very hidden. An autistic person can be very distressed by the feeling of clothes on their body, for example, but they know they have to wear clothes. And that can consume their day just figuring out how to tolerate the sensory sensation of their clothes. So they may have heightened or reduced sensitivity to sounds, lights, textures, smell, or touch. We heard that quote earlier about hearing the electricity surge. I hear that all the time. Folks are sharing with me how they have to maybe put their phone under a pillow, or they can hear the light, the electricity and the lights are in the refrigerator, and it's very hard to filter out. They can experience sensory overwhelm or shutdown in overstimulating environments and enter autistic burnout from intense and effortful hiding of autistic characteristics. So we often work with adults who get to points where they feel so overwhelmed sensorially, socially, from having to perform day to day at their jobs or with their friends to a point at which they have no more to give. And autistic burnout can look different for everyone. It definitely happens in children as well. It can look like severe emotion dysregulation. It can look like self-injury. It can look like having no more words, even a fully verbal person. So I've assessed a adult female who shared with me that, I'm saved all my words for you for this assessment. And when I go home, I know I won't be able to speak. This is a real and legitimate experience that can oftentimes be misunderstood as a depressive episode. Because it can look similar. Sometimes people have to go to bed for a few days to be able to recover, kind of reduce all senses. Okay, more info on autism because I've got your attention and I get to share this with you. It's very often missed or misdiagnosed, especially for intelligent verbal individuals, assigned females at birth, gender diverse people, people of color. Over half my practice is first-time adult diagnosis, particularly for assigned female at birth, non-binary individuals, people of color, intersection of those identities. But trust me, I still see a lot of assigned males at birth as well, later in life. Adults often think they're broken or something is wrong with them until they receive a diagnosis. They don't understand how everyone else around them seems to be achieving adult milestones that they can't figure out how to do. They ask, where was the manual? Who taught them how to do that? I've read all the books and I still find it challenging. They feel like something is broken within them, and nothing's broken. They have undiagnosed or misdiagnosed autism. And adults come through our doors when they're experiencing interpersonal or vocational challenges and or mental health distress, typically, making them seek answers. Self-diagnosis could be its own talk. It's, I consider it legitimate. I wonder when I'll be out of a job. I don't see why I, as a medical professional who's non-autistic, get to tell you that you're autistic. It doesn't make sense to me. I do see why people seek out an official medical diagnosis, how that can lead to insurance and accommodations and documentation, because that's the system that we live in. But a lot of times people are coming to us for a diagnosis who they're just like, this is my experience. Is it autism? And we're like, yes, that is your experience. It is autism. It can be more simple. I talked about that straight line spectrum before. The DSM-5 has 3 levels. I search a lot. There's only child images online of these 3 levels. It drives me insane. So this is what I've got for you. There's 3 levels. They're non-specific. And so then people tend to think the autism spectrum looks like a straight line where you have less to more autism. And so I invite you to think about it differently with an image like this that's been put forth by an autistic artist, where it may look more like a circle that has multiple pie pieces that are, humans are complex. They're multifaceted. There's many things going on with them. And it's not static. So at some points in someone's life, they may need more help with this and less help with this. And it might ebb and flow as someone gets older and goes through life transitions. We've used this a lot in our adult services program at UCSB for folks getting an adult diagnosis to understand more about how autism might be impacting different areas of their life. We've gotten great reviews about using this, forming their own circle, whether it's electronically or on paper. And then thinking about how no two autistic people are alike. And so these 2 circles are 2 brothers who have the same quote unquote amount of autism, but they're different people. So why would we think that they're the same? I've talked about masking. This is one of the main points I hope you walk away with, is that all the characteristics that I've described can be masked or hidden and not necessarily observable. Autism can be more observable. There can be people who you might, by looking at them, maybe tell that there's a difference. But there's many, many people who you might never know by looking at them. And the DSM-5 criteria has done us such a disservice, is that the criteria as written is 100% observable. And all of our autism diagnostic measures, for the most part, are based on what you can see in the room during a 45-minute ADOS. And it's just not, it's not where we are now. We need new measures. I've talked about the social masking. The DSM, I know I'm not a fan, but they do have one sentence I appreciate, which is, characteristics may not become fully manifest until social demands exceed capacities or may be masked by learned strategies in later life. So thank you, DSM, for including a statement around masking, or that there may not have been a full manifestation of autistic characteristics in early childhood. Or there may have been masking. Maybe a parent interview doesn't reveal clear autistic characteristics in childhood. That doesn't mean that the person is not autistic. We've touched on these. Constantly performing and masking and hiding your authentic self can lead to extreme mental health challenges, depression, anxiety, suicidality. And individuals can appear quite socially successful, but again, this takes a significant amount of effort and can lead to extreme exhaustion. This is a great resource. I'll be sharing my slides. Free access self-report questionnaires on a number of different things. It scores it. It gives you, it's very user-friendly, gives you an understanding of the results. Some common misdiagnoses in my practice. So I see between my 2 jobs about 100 cases a year. I mean, the list goes on and on and on and on and on and on and on. My favorite are the ones where they have previous diagnoses of social anxiety, ADHD, OCD, oppositional defiant disorder, sensory processing disorder, and sleep disorder, plus major depressive. Like, it could go on and on and on. I see people with 7, 8, 10 diagnoses in their life. When, as diagnosticians, we are diagnosing the pieces that we see with discrete diagnoses, there needs to be a question of, is this autism? All of these can co-occur with autism, but understanding the root of these things is crucial for informing care. OCD and autism can co-occur, but there's repetitive behaviors in autism that are not OCD. So my my bottom line, and for folks who know me on the call, I talk about this all the time, is that everyone should be thinking about autism all the time because we miss so many people. That 1 in 30, underestimation. Okay. Okay, I'm getting riled up here. Assessment services at Kegel, and then I'm going to move into practical care considerations. We have autism-focused psychological evaluation services at the Kegel Autism Center. We take self-referrals. We do not take insurance. We do have financial assistance to offset costs for those who demonstrate need. And we typically have like a 6 to 12-month wait list. I do only assessments in my private practice. I also do early start evals for regional center. I offer consultations. There's so much power in an affirming autism assessment for children and for adults. It's done in a therapeutic way that is affirming and validating. And having the diagnostic clarity is super powerful for people for how to understand your experiences. And in my care, can shift life trajectories. A 16-year-old who's given major depression, social anxiety, OCD, and sensory processing disorder is going to have a different life than a 16-year-old who's given an autism diagnosis. It shifts care, it shifts trajectories. Some insurance-based autism assessment options, Stepping Stones Group, which is under the Community Autism Services company in Santa Barbara, has autism and ADHD evals for children up to young adults that take insurance. And a really amazing new startup called Prosper Health offers virtual autism evals and therapy for adults that are insurance covered. Okay. So I want to move into neurodiverse-affirming and strength-based care considerations in the therapeutic setting. So in a review of perceived barriers and facilitators for autistic folks accessing psychological treatment, reviewed 12 studies that reported on this. The most commonly reported barrier was lack of therapist knowledge in autism or an inability or unwillingness on the part of the therapist to tailor approaches to support autistic clients. And I get why this is, because in our training in graduate school, it's likely that there in a developmental psychopathology class, there was 1 hour on autism, and probably that hour was focused on children. And so if you see teenagers and adults and older adults in your practice and they're reporting a diagnosis of autism, it feels out of your scope. I want to encourage you to think about that it could be potentially within your scope of practice, because there's so many barriers for 1 in 30 individuals accessing mental health care. Bouncing between providers, being referred out, not believed to be autistic or not seen as severe enough. The therapist tells them they can't see the autism. So a client might disclose hidden experiences that are along autistic lines, and the therapist says, well, I don't see that. That's language that's coming from our cultural implicit bias that you can see autism when you can't always see autism. Maybe they have their own communication challenges of like describing what's going on for them that is hard. And then ultimately there can be a lack of trust in the therapist if they don't feel like they can share these experiences. And honestly, there's not a lot of research on this, and few have even identified facilitators to accessing services. There isn't good research on how to support autistic people outside of our more traditional behavioral models. And in graduate school, I grappled all the time with I was trained in behavioral autism and I was trained as a mental health therapist. How do we put those two things together? How do we support an autistic adult who has co-occurring mental health challenges? We're still not there. We still don't know. We don't have the research. So, I want you to be thinking about kind of strength-based and motivation-based. I'll go into it in a second. So neurodiverse affirming care, what does that mean? The way we practice it at UCSB is thinking a lot about modeling like we're not talking about deficits, we're talking about differences. We're being curious, we're interested, we're learning, we're believing. We are affirming differences and also teaching the skill set that the client is seeking out. In a therapeutic space, there can be the assumption that if I'm seeing an autistic client, I need to treat the autism and I don't know how to do that. But that's not what you're doing. Changing the therapeutic focus from that potential expectation that I need to modify autistic traits to instead addressing the comorbidities while fostering a coherent autistic identity. Support that enhances well-being by reducing distress caused by comorbid conditions without suppressing autistic characteristics. So for example, the adult services program we have at UCSB, it's behavior skills training. It's not mental health therapy. A lot of our folks also see therapists. They're not coming to us to help for us to help them with their autism. They're coming in for us to help them find a job, to maintain their job, to seek workplace accommodations. They are UCSB and SBCC students who want help navigating where do I find the office hours for the TA? How do I write my professor? How do I advocate for myself? So you can see those aren't goals that are autism based. Those are goals that are related to the challenges they're experiencing from their autism. And we want to respect their unique ways of being rather than trying to change them to fit arbitrary normative societal standards. Things like eye contact, or that there should be a certain number of times they see people in a week. So some practical considerations. Be willing to listen to autistic voices rather than relying on outdated models. A lot of people don't get the continuous training in autism because that's not your area of focus, and that's completely fair. At the same time, I'm seeing people all the time in my practice who feel dismissed when they're seeing mental health providers who think that if someone wasn't already diagnosed, like if they're an adult and they did not already receive a diagnosis in childhood, then they can't be autistic. You can still be autistic even if you didn't get a childhood diagnosis. And in terms of building goals, meaningful life goals for the client, are they strength-based goals? In our program, we're thinking about actionable goals that are time-based, they're measurable. Do we know that we're helping you? And then how are you involving the client's voice in goal making? Are you considering the role of the environment and how it is disabling? And I'm even thinking about the traditional therapeutic room and skills as being disabling. That's what autistic people are finding. To the greater macro environment of their workplace or, the spaces that they're in that have certain expectations. And are the therapeutic goals being developed from a non-autistic perspective, or are you considering the neurodiversity paradigm? So again, getting into how acknowledgement of the environment being disabling. What I love to do is talk to people about this because my hope is that even locally in Santa Barbara, we can make a shift in understanding how we can change our environments to be less disabling for people with differences. There is some research on the experiences of autistic adults in mental health therapy, and there are some helpful things. I'm going to go into a little bit more. What I'm offering today are quite practical strategies. So these are things that you may not be thinking about, but things that you can easily do. I'm not going to be going into like exact therapeutic strategies because we don't really know what those are, based on just like a lack of research and understanding. But modifying your environment and having an understanding of the potential that the client sitting across from you or next to you, so we don't implicitly expect eye contact, could be neurodivergent, could be autistic. So therapist acceptance and understanding were seen as critical for success. things we mentioned earlier in our little exercise around, what is going on when we're having a conversation with someone. Everything, most things in our world, the default is verbal communication. And those expectations can be challenging for autistic people. Some things that I've mentioned can be a lot of effort to physically talk about your experiences. Someone might be entering autistic burnout and have less access to their speech. They may be more comfortable using a written form of communication. We've done sessions where we're using the Notes app on someone's phone, writing things down in between us. Of course, if it's virtual, you can use the chat. We have whiteboards where we can be actively writing things down, taking a picture and sending it to the client after. There can be difficulty talking about feelings. So I know kind of it's a stereotype. We go to therapy to talk about your feelings, but the experience of feelings for autistic people can be very different. And there can be assumption from the mental health provider that this is the way that feelings are experienced based on their training. And for a neurodiverse person, it could look very different. So this quote was, "The general talk about feelings is not helpful. I don't experience feelings like most people. That makes this difficult and not very helpful." Sometimes we've heard from folks that, a non-autistic person might make the assumption that the feeling is the most important piece of an experience. And for an autistic person, the feeling might fall much lower on the list of the salience of that experience. And so really understanding from that person what it's like for them to name feelings or talk about them. And maybe that's not even a part of what we do. And we're doing more practical, strategies for their life. Having a clear agenda with well-defined goals felt most helpful. So autistic folks do appreciate structure and knowing what they're coming into. Often in our program, we are setting agendas and our goals are always well-defined. We want to know why we're there. Does this feel helpful for you? And are we making progress on what you want? And then thinking about the sensory piece, access to fidget objects and visuals was found to be helpful. If you're seeing someone on telehealth, you can invite them if they have fidgets or something that they'd like to use, they're welcome to use it. Being explicit about affirming differences in sessions can go a really long way. So I'm going to talk more about a few more of these pieces. I mentioned this earlier, being clear and explicit in all communication, verbal and email communication. If you're working with children who may be neurodiverse or be autistic, we know autism is highly genetically based. It could be the case that you're interfacing with an autistic parent. Clear communication and everything is very, very, very helpful. We work with UCSB students who will not reply to text messages or emails at all and lose jobs and fail classes because the emails that they're getting don't have clear expectations and they don't know how to respond, so they just don't. Open-ended or vague questions can be difficult to interpret or answer. I know at UCSB in our second year or first year helping skills and therapy class, it's all about asking open-ended questions and vague questions. That's not going to be as helpful when you're working with someone whose brain benefits from more direct language. A lot of therapy rooms are set up to implicitly expect eye contact. And so we've been thinking a lot about how to shift things at the Autism Center here at UCSB. We have a room that the couches, they don't face each other. They face different directions. And a lot of our adults enjoy using that room because there's no expectation that there's eye contact. You can also ask someone, what is it like for you to make eye contact? I mentioned this already. Asking the client what they find most important, like what is their priority? I don't know if anyone on here watched The Pit, which is an HBO show it's like a medical drama. There's an autistic doctor and an autistic client or patient comes through and he has a sprained ankle. And there's a lot of things that go on that are amazing. This doctor is amazing, picks up on the patient's autism right away. And the non-autistic medical attending is asking all kinds of questions that are aggravating and irritating the autistic patient. And the autistic doctor, she closes the door, she goes up next to him and says, "What do you find most important in this situation?" And for him, what was most important is that the sprained ankle lost him access to, like, I forget exactly, like the tennis table tournament he was training for. That was his priority. It wasn't the pain from his ankle. So are we asking, what is the priority you have here? And then being comfortable with different communication styles. I mentioned written expression. We know that neurodiverse brains can have some delayed verbal processing and auditory processing. So a lot of folks we work with really, really benefit from having visual redundancy to what is verbally discussed. So sometimes if that's a telehealth session, we have a working document where we're, going through the main points of the session, and then that document, is sent to them to read later. Again, we use the Notes app or the chat. Talking about what is verbal communication like for you? Would you prefer to use written communication or electronic communication in session? We can use our Notes app. We can use a journal and write back and forth. Having fidgets in the office. There's so many amazing fidgets. So many amazing fidgets. Or when you're at an intake with a client asking, are there things you'd like to bring with you from home if it's in person? That would make you feel more comfortable in session with me. Sometimes people bring in fidgets or weighted stuffed animals. I mean, I'm talking about all ages. There's just some really cool things out there now. We're so stuck, and I know for a lot of different reasons, in a certain time frame of session and how often we see people. Can there be some flexibility in that? Is a 50-minute session too intense? Is there a way to make that look different? Visual supports, I obviously want you to remember that because it's everywhere on my slides. Think about how stimulating sensorially the office is. Can we make it low stimulation? Can we invite clients to bring in things that help them be better able to manage their sensory experience, acknowledge the sensory experience in the room? At UCSB, we have fluorescent lighting. It's absolutely awful. Whoever designed the Autism Center way back when, it's horrible. So we're thinking about how we can put things over it to just make it more pleasing. We can dim lights, we can have darker lights, offer fidgets, and at all of our events, we always have a sensory calm down room. I mentioned that sort of a little bit taking longer to process information. We hear that a lot from adults. They've even been asked, wonder if they have a hearing impairment, but their hearing is fine. There is more time required to process what is going on. And it can take maybe the whole session to answer a question, or maybe a week to answer a question. And so giving people time to really think about what it is that you're asking, and then for them to respond. Often in our sessions and in our assessments, folks are bringing in pre-prepared multi-page Google Sheets. We don't ask people to do that, but they're coming in having written down their experiences for years, hoping that at one point someone will read it, because that really helps complement our, honestly, more verbally based testing. We think a lot about motivation when it comes to helping our folks. So really honing in on interests and passions can be really crucial to success on goals. So is there a way to incorporate, if your client has an intense interest or passion, how can we incorporate them directly into their goals? And what we hear sometimes is that maybe the healthcare provider they're working with doesn't really want to hear about their interests. And that is too bad, because it's a rapport building. It's establishing, if the person wants to talk for 20 minutes about tarantulas, let's talk for 20 minutes about tarantulas. That will do such a service in building that rapport and trust. So we use several sessions in our program to learn about interests and passions. An example could be, if the client's super into astronomy, using a solar system as a metaphor for stress management, where the client's an astronaut, the stressors are asteroids, and the coping strategies are tools on the spacecraft that the astronaut is in. Create a coping constellation map. Each star is a coping skill learned. And then this is language that can be used weekly to troubleshoot, review how things went, and build on already learned skills. This might be more accessible than talking directly about the feelings that the person is having, associated with these stressors. And importantly, it can be a handout and something that the person can refer back to as needed. Okay, a few takeaways. For an autistic client, you're not treating the autism. You're providing support around what feels disabling and challenging within the context of the autism diagnosis. It's likely that a lot of folks don't have an official diagnosis, but there can potentially be strong mutual suspicion between you and the client. Of course, you can use these modifications. Honestly, these can be used for everybody. And like I mentioned, the number one reported barrier from adults is that they've been dismissed by mental health providers. So taking the time to believe and listen to them. And it's even gone so far as someone's child got an autism diagnosis and then they realize that probably that's also their experience. They call up their insurance and the insurance won't approve the request because the person is an adult who has a child. So it's immediately dismissing that the assumption that autistic people can't have families. It just makes no sense. Okay. And then if the client is interested, referring for assessment. We've heard really powerful stories of where the therapist maybe suspects autism and they bring it up in session. And if it feels like the rapport has been established, they take a look online, they look at it together, and someone who might have been treated for 30 years for depression and anxiety has that moment and seeks out an assessment and finds more about themselves. Okay, I'd love for you to write down 3 ways, 2 to 3. Write down for yourself 3 ways you can adapt your work to meet the needs of autistic clients based on what we've talked about today. So take a minute to do that, please. If you'd like to share in the chat, you can, but it's not the expectation. Okay, I'm going to move on, but I want it to be, oh, thank you, Anahita. Making sure fidgets are more readily accessible in the office, continue reminding my patients that they can bring them from home. Yeah, it's such a simple thing. Having like fidgets in the waiting room. Yeah, exactly. Okay, great. I want to talk a little bit more about, oh, Charlotte, thank you. Asking what they find most important in the situation, reducing feelings, talk, and asking a minute questions, hard. Yeah, I wish there was a course in grad school that was helping skills for neurodiverse clients in therapy, that we had that here. Okay. At Kegel Autism Center, we do have an adult program. We provide support on social communication, time management, organization, daily living. It really ranges. We also work with a lot of folks who have received adult diagnoses and want to unpack that and understand like what that is. What might it look like to unmask? What does that even mean? I've been masking for so long, I don't know who I actually am. It can be what we offer is up to 4 hours. It's behavior skills, like I mentioned. It's not mental health therapy. It's 1 hour with a graduate student in the doctoral program here. And then if the client wants, up to 3 additional hours with a trained UCSB undergraduate. We see all ages. So sometimes it's a 21-year-old undergrad working with a 50-year-old client, and it actually usually turns out pretty well. It's private pay, runs during the academic year, so we're maintaining a wait list now to open in September. The goals are client-driven, and sometimes it can complement mental health support. We have a partnership with the zoo where we offer in the summer once monthly autism safari nights. So parents of autistic children can drop their kids off to us at the Discovery Pavilion, and we provide the childcare. It's a super, super fun night. We have one more on September 11th. You can register on the zoo website. It might be full. If it is, you can email me and I can see what we can do. At UCSB for students, we have Team, which is a supportive hangout group for neurodivergent identifying UCSB students. They do so many different things: game nights, pizza parties, study jams, D&D. They make like mug cakes in our microwave. They do all sorts of fun stuff. And then we also have an art hangout club for adult community members. So you do not have to be associated with UCSB to attend. It's creative club in any sense of the word. We do creative projects. Coming up on November 17th, we're putting on a conference with YouthWell and other participating organizations, just bringing people together to talk about neurodiverse youth, how best we can support local neurodiverse youth. I also want to plug our twice annual art show that was born out of the Creative Club, where folks wanted a space to show their art and sell it. And so now we are looking at our 7th art show to happen on December 4th at 5:30. It's at the Kegel Autism Center at UCSB. We have sponsors, we have food, we have refreshments, we have drinks. It's a beautiful night. All ages submit art. We go from like a childhood sketch to a professional artist submitting art, and 100% of the proceeds go to the artists if they'd like to sell their art. It's a really special night. If you've never been to the Kegel Autism Center, this is the night to go. And these are old flyers. I'll share the new flyer on happenings when we get it. Lastly, thank you so much.